Yeah, and I'm going to try and keep it as light-hearted and relatively short, and I feel like I should defend myself, saying that when the stroke thrombolysis works too well, and they end up with a hematoma or an actual stroke, we bail them out and do the craniectomy, right? Neuroradiologists are overrated. We look at a lot of scans, but if we get stuck, we help them. No, in all honesty, I think why neurosurgery is probably quite suitable from that point of view. But we work together, and we're very intertwined. All of this, and I think in terms of neuroscience, if that's what you want to do, you just have to find your personality for whatever is suiting you. So we're dependent on each other, we help out, and even if we have a bit of a battle kind of thing. All right. Nonetheless, very briefly, I'm Anne Elserius. I'm one of the West Midlands neurosurgical trainees, and I'm coming towards the end, which is a bit scary, ST6, and I'm actually from Sweden. I've been in England for 10 years it is now. So I went through medical school in Uppsala University in Sweden, and then before that went to a school where quite a lot of my friends from there moved to London, so I thought I'll give it a go and see what England's like. Did an elective at King's in London, and then came across and applied for my F1, F2. I ended up in the East of England Deanery, and I spent 2 years in King's Lynn in Norfolk, if anyone knows where that is, which was a very nice small DGH and introduction to sort of British way of working. I applied to neurosurgery, and I told some of you that people were telling me, oh, you need to, apply for orthopedics and do general surgery, and I said, no, this is what I want to do. And I went ahead, and I got to reserve for the interviews, so I didn't get through to interviews the first time around, and needed to put maybe a little bit more on my CV, so I did a LAS intentionally so I could apply for an ST1, because there are all these rules in terms of how much neurosurgery you can do before you apply. And I ended up in Romford in London, which was really good. Reapplied and got to interviews, and somehow ended up with a training number, and as a trainee in West Midlands. So,
sorry, I think many of us don't know what LAS is.
Oh, sorry, it's like a service provision. So you have various pathways. So the main aim is sort of to become a trainee. So you get onto the run-through program, right? So there's not enough numbers to fill it up, but there's still doctors required, because we've gone from a system where you used to be an SHO, and like you said, you move around from different specialties. So if you wanted to do neurosurgery, you would do 6 months neurology, 6 months ITU, 6 months ENT, and you would gather it all together, and then you would get a number. And I'm not really sure how that was sort of worked out, but now it is one sort of national application, and you get on and become a trainee or not. But to fill the gaps, there's something called an FTSTA or a LAS or a LAT. And these are kind of training numbers, but they're only a year at the time. So I'm not going to go into the various, because there's too many abbreviations, right? But it is a way to see if it's really what you want to do. You get the flavour for it, because I was more or less treated as a first-year neurosurgical trainee in London, being outside of the whole training scheme, but still doing neurosurgery, if that makes sense. So, yeah. Feel free, because, like I said, I'll try and keep it relatively light-hearted, so just ask questions. My first contact actually with neurosurgery was when I was equivalent in high school. This guy, Dr. Ben Carlson, he's an American neurosurgeon, as you can see by the flag. He came, and it was just actually after he separated the craniophagus twins, so conjoined by the cranium, 2 separate brains, right? But and he went on a world tour, more or less, and had his presentations, and he came to Stockholm, capital Sweden, and awed us all with his performance, and he was very good and very sort of enthusiastic about it, and I thought, oh, that's pretty cool. And then I went through medical school, and like I said to you guys, I thought I was going to do neurology to start, because it's a bit of a logic map you read, and you a bit of detective work, right? And then went through and did my surgical training placement, and just love working with the hands. Now, everyone doesn't go on to become a presidential candidate. He works within the Trump administration now, I think, so we'll skip that one. Right. So I'm not going to bore you with history, but just it's been around. So video, if it works, it's not exactly rocket science because it's just a hole in the head, right? And pretty much 7,000 years ago is, I think, the late sort of backtrack to where they found cranial skulls that actually healed up, meaning that, or healing towards healing, meaning that the patient did survive these sort of interesting burr holes with in a treatment of passage of spirits, as you see, or treat pain or seizures or migraines or mental health disorders, right? That's obviously not any indication today. Then, very briefly, Harvey Cushing was the first exclusive neurosurgeon, if you like, obviously the first person to describe what we know as Cushing's disease. He had a huge impact in terms of the survival, especially following different tumour surgeries, so bringing neurosurgery forward. Lifespan, I think it's 1869 to 1939, right, so covering the First World War. He also used radiographs or x-rays to do certain diagnosis, not entirely sure how, but on calcification possibly. And he also used some electrical stimuli to have a look at the sensory cortex. So here you've got neurophysiology, you've got neuroradiology, you've got neurology, right? So it's all from the beginning. Further on, I've just mentioned Yasagil, he's born 1925, still alive, founder of microneurosurgery, so two sort of foundations from what we're doing today. And he's Turkish, written loads of books. So modern take on neurosurgery, you all know Dr. Shepherd and Dr. Gray's Anatomy. I'm not entirely sure, well, Monroe obviously, but there are also two neurosurgeons. Not really quite what it's like, okay? Real life neurosurgery, I think it's a little bit like it's already been pointed out. You probably know or have a very good idea of if you want to do it, and you should walk into it with open eyes and realize what it is. And doing this, I had to sit down and have a little think, and I put down these words, where it is exciting, right? And it's a benefit of you never know what's coming through the door, right? You have a day planned out, and most of the time it never turns out the way it's supposed to be, which I enjoy, right? Because it gives you the adrenaline rush, right? You have this major trauma coming in, you're in A&E, and there's a huge head injury, and you get to take them to theatre, and you're the one pulling all the strings and making sure it happens, and you get to do the surgery, and it is, or a really nice tumour case, or if you're into spine, then there's everything, and those are the highs you live on, all right? So that's for your benefit, if you make sense, but then it's a huge privilege, okay? Because you are literally, you've got people's lives in your hands, and it applies to quite a lot of specialties, right? But it is a touch and go, or life and death. With a stroke, equally people come in, and it's down to you to make sure that you're feeling well enough, you've eaten well enough, you've slept well enough to be there to look after them, okay? It can be demanding, or it is demanding, I should say. It's relatively long hours. You don't walk up and leave in the middle of a surgery. We had, I was in scrub with my consultant, and the anaesthetist was there with his consultant. Come 5 o'clock, the reg said, right, it's my time to go home. I've working directives. And the consultant anaesthetist said, yeah, no, that's fine, good, thanks for today, you've done a good job, and he was on call, right? So I turned around to my consultant and said, right, it's time for me to go home, and he just laughed. It's not really quite, there. But it is a pleasure. So it comes with certain sacrifices, and coming with the fact that you don't know what's on the table, you can also end up having to cancel dinners or social engagements, or you have to be prepared to give a little bit, okay? But the flip side is that it's extremely rewarding, okay? It sounds also like a bit of a cliche, but having a thank you from a patient. I got a teddy bear with a knitted sweater saying thank you, Anne, right? That sits on my on my desk, and those things drives you in a way. And when things are really rubbish and you're just up to here with stuff to do, you can go back to these things and think, oh, actually, it's not that bad. So a normal week, I put it in not brackets, but is very thrown, and it depends on, as a registrar, it depends on what's on your rota. So next week I have a week of nights, so I come in, do Monday to Friday night, and on that anything can come through the door as on calls. Surgery is obviously a current theme. You go to theatre with your consultant depending on what days to have surgery, and then obviously placed in other lists as well. We do weekends, we do nights, we do late evenings, even when you have a normal day, you probably do evenings anyway. We do have clinics because we need to see our patients before we operate on them. And if you can't, it's maybe something we don't enjoy all that much, but equally, if you can't see a patient and make a decision in clinic, you can never become a good surgeon, because you need to know what to operate on and what not to operate on, okay? Admin is something that's just on there. Otherwise, it's quite similar. It links in with with what Dr. Mather said. We have MDTs, obviously neuro-oncology, spinal MDT, all these kind of things that are very important to make a joint decision for the patient's best interest. Okay. Just as an example, theatre day, usually we start at 8, right, but you have to probably be in by 7 because you want the theatre to run at a reasonable time, or at least not be blamed when it's a late start. So you come in and you consent your patients, going through with your consultant the day before what you're going to do. If you have time, you go to the handover meeting, so taking in what's on call, have come in, or what's been discussed overnight. Team brief for theatres to make sure that theatre staff knows what you're doing and what instruments and equipment you need. And then depending on what kind of theatre, there's either 3 or 4 cases. After every case, you do an operation note, so you give specific instructions, and always see the patient, obviously, in recovery. And as opposed to other specialties, I guess, we're always keen for them to wake up, and they don't always do that. And then you go home between anything 6 to 8 o'clock, or depending when things finish. So in terms of, there are obviously various types of subspecialties. I think I'm just going to run through things that will come in from our own call, and feel free to ask whatever questions. You've already seen a picture of a subarachnoid hemorrhage. You've got, I think this was actually a PCOM, but you've got the circular villus, quite heavy blood load. It looks like an MCA actually, but typical presentation with a thunderclap, headache. You've got a World Federation of Neurosurgical Society grade. All right, grade 1 is a good one, grade 5 is a really poor one. And it is a neurosurgical emergency. And we do have help from our neuroradiology colleagues with a coiling, but it's also possible to, if there's a big clot sitting here, and actually I think she did have a clipping in, a clipping in the end, because if it's an associated big clot, then you're better off actually ruining the skull and taking the clot out, right, and putting a clip on that. But unfortunately, it's a dying specialty with vascular neurosurgeons, because our radiology colleagues are all that very good at coiling it, so we're not needed as much from that point of view. And then keeping out for hydrocephalus, vasospasm, rebleed. These are the 3 sort of complications from a subarach. And a little bit of imaging. So this is the same patient, actually. You can see that, so this artifact here, so actually I'll point out, that's the aneurysm, that little blob sitting there, right? So you've got the, spun that around. Yeah, I think that's the ACOM there. You've got the anterior cerebral there, and PCOMs, and then the ICA there. Nonetheless, that's the artifact given by the, I think this might have been coiled, but then we intervened anyway, and we didn't touch the clot, but we took a bit of bone off here to give the brain space to swell, so as to prevent her from coning and a certain death. And that little bit there is an ICP monitor, so we like putting those in to make sure we've got a reasonable idea of the pressure. Acute subdural hematoma, okay, that might not be the best scan in the world, but I remember this guy because he was an alcoholic. He was walking around and he was found walking around, but he probably had his head injury a few days earlier, because you can see all this here was probably a bit more bright white. You've got these bright white streaks here, which indicates the acute blood, and he's probably had a big clot here that settled down, okay? But he's got midline shift. You can see this whole brain side is pushed towards the right side, he was not, obviously the Kelly Monroe doctrine, he's probably been sitting a little bit here for a few days, and then he's at the point where he's not able to compensate. So I took off half of his skull. It doesn't look much there, but you can see this big flap here is taken out and put his abdomen, or thrown away depending on who the consultant is on call, just to give him a bit of space and have a chance of surviving. Likely kept asleep for a good few days in ITU, just to let him recover. Extradural hematoma, another emergency, and this is the lucid interval. So when someone gets hit on the head, they pass out, wake up and reasonably okay, and then just go. So first one to the primary insult, second passing out because of the hematoma getting bigger. So we tend to put the bone flap back. So just went in, opened up here, took that out, didn't really go into the brain, and just put that flap back, kept him asleep for a little bit, and then actually woke up quite well. There was talk about radiological diagnosis here, but cauda equina, I think, is more of a clinical diagnosis than actual radiological. You can see spine here between the fifth lumbar, so L5, S1, you've got a very big disc pushing onto nerve roots, right? This is a scary scan. But equally, I've seen patients with this kind of picture not having that much of a neurological symptom. But if this is associated with weakness or cell anesthesia, urinary incontinence, bowel incontinence, and painless retention rather, they need to come in and they need surgery within 24 hours preferably. Okay. Other things, spinal fractures. It is actually a relatively heavy spinal workload, I think, within neurosurgery, on call in particular. These two, this is the same patient, but that's not necessarily his injuries. He's probably got fractures all the way through the spine and thoracic fractures, but this is more likely an elderly gentleman. You can see the C-spine, and then it's a nice little gap there, and it's highlighted here. That white bit there means that the whole ligament in the front of the spine has just opened up, so he's probably fallen over and thrown his head back, and if he's on a particular sort of MRI scan, he would have quite high signal, meaning it's a very unstable C-spine. Okay. Point with polytrauma is that we get involved obviously from the head and the spine point of view, but it's really important remembering that it's the whole patient, right? These guys come in and they've got hemopneumothoraxes, fractured pelvis, long bone fractures, everything with the blood pressure is down in the boot. So it needs, again, teamwork from all specialties. I know even neurosurgeons are lone wolves, but we do work in teams. Other things, metastatic cord compressions. This is a particularly horrid picture, and I actually had to borrow this one from the good World Wide Web, I was about to say, which likely has been metastatic involvement and then just a fracture by a dislocation, obviously, and unlikely any function whatsoever from this level and below. Highly unstable. And what's important from our point of view in this is it's easy to look at the scan and think, oh, you need to do surgery, but you also need to know what's the prognosis for the patient, what is the primary tumour, is this something that's beneficial for the patient, right? Do we want to go in and do a massive fixation with screws and rods and someone who's got 3 months to live? No, it's not. You need to try and look at the patient's best interest and see, and that comes back to, in when to operate and when not to. Brain tumours, obviously quite a heavy load from our side. Basics in terms of, is it a primary high-grade, low-grade glioma? Is it a secondary? Where is the secondary? And again, what's the prognosis? Benign or malignant, is it a meningioma or any of the others? And surgical, non-surgical, and this is where the MDTs come in. Right? We need to have help from specialties and come up with a joint decision. What's the best outcome for the patient? So if this is something that you still think you want to think about, the neurosurgical pathway, and I think it's similar. Like I said, it's a national selection. It happens once a year, and it is this Oriel now it is oral online applications, and you fill in, I think when I did it, it was about 10 or 12 pages. And it's a run through. So once you're in, you're in, okay, ST1 till ST8. You have to do the MRCS, which is covering every surgical specialty, as I'm sure you know, and to be able to progress on to ST3. So if you haven't got it before you apply, you need to make sure that before, in your first and second year of neurosurgery, you do the MRCS, and you become a Mr. or a Miss, right? Just to highlight the fact that we're not physicians. And then we do our FRCS, so for neurological sciences, neurological surgery after ST6. So I'll probably be doing mine in January next year. And SBNS, the Society of British Neurosurgeons, right, have meetings every 6 months, and their webpage is actually really quite good in terms of looking into. They have a specific section of what to do and what pathway to take if you want to do neurosurgery. And how to get an interview, or it's pretty basic in terms of what's been mentioned before as well. You show an interest, right? Audits or research or projects. You try and get hold of the specialty that you want. And I know we're maybe sometimes a bit difficult, right? But we're not completely impossible. A taste a day or a week, just to get an idea of what it actually is. Presenting at the SBNS is always a good way of seeing various different people and talking to them, and even if it's completely anonymous or is a national selection, it's always nice to have a chat to people around the country, because it's as much as we submit our presentations and these bits and bobs, it's very much a social event and catching up. And then I think I want trainable doctors and looking for future colleagues, because this is what someone told me before I did my interview. And it is really basic, isn't it? It's just you look and see, is this someone that I want to work with, and that makes you more keen to teach. And it comes with, if you show an interest and if you have genuine things in your logbook, then that's a given, right? If you want to do a bit of reading outside of it, Mr. Henry Marsh, some of you might know him, he's, I think he was at George's in London up until only a few years ago. He's been frequent in media as well, but I've read this one. I haven't read this one yet, but it's actually not bad. And even if you don't, really want to do neurosurgery, he's very honest and open. And I promise I'm not taking any commission, right? But it's quite good. Right, then I put a picture of me and my colleagues just to highlight that you spend a lot of time together, and you get to see each other at your worst, really, as you do the long hours, the nights and the holidays, and you form quite a tight band with them, and it's really nice, because even if years passes by, then you still catch up and good friends. Then I'm not sure, this is just for fun, right? You guys might have seen this. Can I click that? And you have to, it might be how some people see neurosurgeons.
I think you might need to click escape, so I didn't bring it up.
Escape. That's not the one. Oh, hang on, it's waiting. Enable. We'll enable it. Ooh, maybe not. An error occurred. Okay. I'm not going to do anything with that, I don't think. Nonetheless, it's a silly one, really. He's a guy who just.
Maybe try again, but I think it's a.
And otherwise, we'll definitely post the slides.
Yeah. He's just being a bit of an idiot at a drink party, and he meets a rocket scientist at the end of it. So sorry, I've ruined it now. Anyway, that's it. And I put this is actually from being a Swede. I was on skis when I was 4, right? So it's just to highlight that it's a lot of hard work, and some people literally live and breathe neurosurgery, but I think it's really important that you have a life outside as well. So you get a bit of a break and you have somewhere to vent. Okay, so that's it. question. Yeah.
Can I ask, to what extent is your work split between acute trauma patients and more planned, like tumour infections or something?
So you
do you specialise?
Yeah, you do have trauma as a specialty, sort of neurosurgical. But I think as a registrar, that's when you obviously become more independent. You on your own calls, you get all the traumas, right? So you do the acute subdural, extradural, sometimes cauda-equine, and all these kind of bits. But then most units have an allocation, so you're working with a consultant, which means that you are in their elective planned list on a normal day, right? So you do get a little bit of everything, but it's more likely in terms of the amount of surgery you'll do will be limited until you get more senior, because obviously an elective case should not have any flaws. Not that I'm saying that the emergency ones will do, but it's a completely different. You could argue that some of these, like I said, I didn't even touch the brain on that one. You just do the actual plain simple surgery. You take the lid off and make sure that you don't do any harm, right? Whereas elective surgery can be anything from skull base to Chiari malformations to possibly. So the more senior you get, the more of the actual surgery you will do, but you'll be exposed to it throughout your training. Yeah.
Just with regards to sub-specializations, is that done after your 8 years, or do you have opportunities like within the 8 years?
Yeah, so you have to, so you'll become familiar with something called ISCP. So you go through, every year you go to your ARCP, which is a panel of consultant neurosurgeons that look at you, go through every move you've made during the last year in terms of presentations, publications, numbers of surgery, numbers of operations, work-based assessments, and all these kind of things, right? So you have to fulfill a certain amount of number of surgeries, and within all the widespread from pediatrics to adults and all the specialties. The way it is today, you get when you do your exam and hopefully pass, you move on to aiming to get your CCT, so core completion of core training, right? After that, you tend to do a fellowship, or maybe even 2, because it's not, I can't say I'm looking forward to getting to that point, because it's not all that easy getting a consultant job, all right? And especially if you have a certain specialist interest, you need to be a bit more flexible into where you want to go, right? So it's more the fellowships that will mould you. Then you can obviously strive towards what you want to do during your training, if you know that early on. You know. Yeah.
With interventional radiologists doing more, has that affected your workload quite a lot, and is that viewed as a positive thing, or is it a kind of miss out?
I think from our point of view, what it's done is that less people are going into neurovascular neurosurgery, right? There are very few consultants who actually still do clippings, right? I was talking to one of my senior OSS staff grades, but also consultants, saying that my time, we have to have 20 clippings. I've maybe been present at 3. So it all depends on where you are as well. And I think in America there's more clippings. In the UK it's very much a coiling neurointerventionist part. So I think what it's done is sort of balanced. There's not many neurosurgeons who would do the coiling, right? I know a few, but not many.
Does that present a problem then? Are there some cases that need to be clipped, and if there isn't enough, enough people having done it, will all hospitals be able to offer that?
No. And there are sometimes coilings do fail. Okay, aneurysms have a huge different morphology. So if you've got something that's a very wide neck in an awkward place, a coiling is not necessarily the best thing, because you can probably do it with flow diverters, and it's they have various techniques obviously for it, but sometimes it is a clipping, or if there's an inadvertent perforation, right, and there's a big clot, and then you need to take them straight from coiling to theatre. And what we can do is make sure the clot isn't there, but it's not everyone is happy to open someone up and put a clip on, unfortunately. Yeah.
I was wondering, what sort of things did you do prepare yourself before you apply for specialist training?
So I think I'm a bit of an anomaly because I didn't, in terms of, I knew what I wanted to do. So I think in terms of the CV, I can tell you I tried to get, like I said, I had various different audits and projects. I did my elective during medical school. I was 8 weeks at King's in London. I still, when I see some of those consultants, they still remember and say, oh, you know, you're a trainee. And it's so you link up a little bit also, and people will guide you through if you can get in touch and just have a bit of a try and see what's the best thing to do. But in terms of interviews, I think you do best by being who you are in a way. And it sounds very dull, but it's not. There are not all that many posts around in the UK, and I think comparing it to friends who did general surgery and orthopedics, it was more sort of a streamlined interview, if that makes sense. So a friend of mine who he went through, and he's really good, and he prepared himself and he did it in a very structured way, and second time round he was a bit more personal, if that makes sense. So it's hard to explain because I know there's also a lot of tick boxes to do, but I literally just walked in there, and I could tell you a story about my interview morning and you wouldn't believe me, right? But I thought this is what I want to do, and hopefully it will shine through. And if you have the interest and the keenness, it will be seen. And they're looking for trainable people. You know, that's why there's a limit to, I think, 18 months of neurosurgery. If you've done more than that, I don't think you're eligible to apply for SC1. So there's a balance, obviously, and I know I was up against people with theses and PhDs and written books, and I sat there and I thought, but so there's also you need a good mix, right? So there needs to be a little bit of everyone to balance things out, because there's no homogeneity at all in our units.
I think there was one more question.
Yeah, sorry. Yeah.
If you specialise in a certain aspect of neurosurgery,
Yep.
does that mean you can only operate on that aspect and you can't sort of general neurosurgery?
So general neurosurgeons are pretty much disappearing, okay, because there's such a subspecialised area. So I think Coventry, they're a little bit more general because they do both spine and cranial. The QE in Queen Elizabeth in Birmingham, you're either a spine or a cranial neurosurgeon. And then you're either instrumented, as in fixation with the screws and the rods, spinal surgeon, or not so much and more tumours. Or you are a CSF specialist, or you're a neuro-oncologist, and if you don't attend a neuro-oncology MDT, you shouldn't have the right to do a tumour if it comes in, right? And there's always, there's always excuses if someone comes in with a massive tumour and they're the brink of not surviving, of course, you'll do the craniotomy, right? But it's becoming more and more subspecialised, and you stick to your end, which is why probably it's becoming a bit more difficult finding jobs, because there might be a CSF trauma job, whereas you want to do skull base, and then that doesn't merge up. So, increasingly more.